A clinical prediction rule for the success of cervical manipulation. Manipulation utilized by a number of healthcare practitioners, but primarily by chiropractors, is a relatively common approach. However, there is still a majority of the public that would seek medical management first. Well, why? Well, the concern of safety and the medical perspective that long-term effects are similar among treatment approaches. The evidence for manipulation can be reviewed from the perspective of long-term outcomes or from the perspective of short-term effect. From the long-term follow-up perspective, it appears that natural history and various approaches have similar effects. But given that a patient's acute need is more a goal for an earlier return to function, it would seem important that from the patient's perspective, it would be important to tease out if there is a difference in the short-term effect. They can't often afford to wait to let natural history or long-term effects to occur. The study we will discuss is in fact focused on the short-term effect of a thrust type of manipulation. Although the technique and approach are perhaps more reflective of a physical therapist's approach, the approach is similar enough that it may have some value for chiropractors. So what is a clinical prediction rule and how are they developed? CPRs are designed to assist the clinician in making decisions about one of the following: screening and diagnosis, prognosis, and interventions. Although designated as a rule, they really reflect an algorithmic approach to the patient with the hope that prediction of the intended purpose is much better than through clinician guessing. When would you consider using a CPR? Well, when you encounter problems you do not see on a regular basis, when you wish to demonstrate the scientific basis for a treatment plan you have proposed, and when you want to find a more cost-effective approach. Many CPRs were developed with this as a primary motivation. There should be 3 progressive steps in the development of a scientifically sound clinical prediction rule. They are derivation, this is the study from which the CPR factors are derived; validation, this is when it's tested in a different population of patients; and finally, impact analysis, where it's applied across multiple settings in the real world to see if it is met with acceptance and is practical. So how would you decide which factors are worth paying attention to, the most reliable indicators? Well, it starts with a prospective cohort design. This is a study that follows patients forward in time. Patients go through a standardized exam with a reference standard test, if diagnostic, or a specific treatment, if interventional, or wait a specific period of time, if prognostic. For interventional studies, a validated outcome measure with strong psychometric properties is selected. So what does that mean? The outcome measure, such as a questionnaire on patient function, has been demonstrated to have discriminative value, one that possesses a difference score that identifies a clinically important change for the patient. For interventional CPRs, once the patients are dichotomized into successful versus unsuccessful, variables are compared in these 2 groups to determine univariate associates, meaning each element or variable is analyzed for its own individual value. Those with significant univariate associations are then combined into multivariate analysis to determine the contribution of a group of predictors. Variables that become part of a group may not necessarily be the most significant individual predictor variables. 2 things can now happen. Either these variables are brought together into a clinical prediction rule and published as a derivation study, or in the same study, 2 groups of subjects are used. One group acts as the derivation group, the other the validation group. In other words, that sample of subjects has the rule applied to them to see how well it performs. Scientifically, this is a weaker validation approach because it uses subjects from the same setting, which makes conclusions about its validity for extrapolation to other populations less sound. Ideally, validation occurs in a separate study with a different sample with different prevalence and spectrum of the disease. The last phase, which is rarely performed, is the impact analysis. It makes no difference how scientific your prediction rule is if it's met with strong resistance, is too complicated, too cumbersome, too expensive, or simply not feasible in environments outside of the derivation and validation settings. Judging the quality and value of a clinical prediction rule is important. CPRs have been categorized into 4 levels for that purpose. You can see that level 1 is highest, with at least 1 prospective validation study plus 1 impact study. There are very few of these. Next, we have level 2, where at least one large prospective multi-center application has been performed. Level 3 means that there is at least one validated prospective study. Level 4, which most CPRs are, includes a derivation study, but the rule has not been validated outside of the derivation study. Now, the current study. The title of the publication is Development of a Clinical Prediction Rule to Identify Patients with Neck Pain Likely to Benefit from Thrust Joint Manipulation to the Cervical Spine by Puentedura et al., published in the Journal of Orthopedic and Sports Physical Therapy in 2012. There are some unique element designs of this study worth pointing out. The first is that this was an international study involving clinics across the U.S. and one in Spain. The 4 locations were Las Vegas, Nevada, Aurora, Colorado, Overland Park, Kansas, and Madrid, Spain. So who are the patients? The inclusion criteria were patients 18 to 60 years of age who had a primary report of neck pain with or without unilateral upper extremity symptoms, and patients with a baseline neck disability index score of 10 points or greater. Exclusion criteria included patients with any medical red flags, cervical spinal stenosis, history of whiplash injury within 6 weeks of the examination, outstanding legal action, 2 or more positive neurologic signs consistent with nerve root compression, or a history of cervical spine surgery, rheumatoid arthritis, osteoporosis, osteopenia, or ankylosing spondylitis. In an effort to determine if there was a nerve root cause of radiation, patients were examined using the standard battery of tests, including the Sperling test, the neck distraction test, and the upper limb neurodynamic test. So it's clear that an exclusion focus was to separate out those patients who had radiating complaints into radicular versus non-radicular. Also, patients were screened for any signs of vertebral basilar insufficiency, such as nystagmus, gait disturbances, and Horner syndrome, as well as for upper cervical spine ligamentous laxity through the sharp Purser test, alar ligament stress test, and transverse ligament test. If any patient had a positive finding on any of these final screening tests, they were excluded from the study. Let's review the treatment protocol for patients in this study. Therapists performed a thrust manipulation at the same level to each side of the cervical spine. The treating therapist recorded whether there was an audible cavitation. If the therapist and patient did not hear or feel a cavitation, the treatment was repeated up to 2 thrusts on each side. Patients were treated for 1 or 2 sessions over approximately 1 week. At the end of the study, patients were classified as a successful outcome based on a score of +5, quite a bit better, or higher on the Global Rating of Change scale. The Global Rating of Change is a scale that on one end equals a -7, which is a very great deal worse, and on the other end a +7, a very great deal better. Additionally, scores of +5 would equal quite a bit better and +6, a great deal better. How patients distinguish from quite a bit better, a great deal better, and a very great deal better is curious. What would make a patient choose a +5 versus a +6, or a +6 versus a +7? This is not clear. Interestingly, only 39% achieved a successful outcome. Although that may seem low, remember that patients were treated only for 1 week with 1 to 2 treatments. In that context, this percentage seems more significant. And also, from the perspective of a clinical prediction rule, it's for improvement for a 1-week treatment trial, which would be considered minimal by many chiropractic treatment approach standards. Of course, what we don't know is the long-term success and whether the improvement was sustainable without further care. A multitude of factors were collected, including gender, age, belief that the treatment would help, cervical spine range of motion, symptom duration, and provocative testing. For the patients in this study, the clinical prediction rule involved 4 attributes: symptom duration less than 38 days, positive expectation that manipulation will help, side-to-side difference in cervical rotation range of motion of 10 degrees or greater, and pain with posterior-anterior spring testing of the middle cervical spine. The positive likelihood ratio for having all 4 attributes was estimated at 13.5. If 3 or 4 attributes were present, the probability of experiencing a successful outcome improved from 39% to 90%. Although there are not many CPRs for manipulation of the cervical spine, there are a few. From this study, the CPR for cervical manipulation, success included the following: initial neck disability score of less than 11.5 points, bilateral pattern of involvement, not performing sedentary work greater than 5 hours per day, felt better while moving the neck, does not feel worse extending the neck, and a diagnosis of spondylosis without radiculopathy. 4 or more predictors indicated a moderate shift with a positive likelihood ratio of 5.3 that the patient would have a greater than 50% reduction in pain or report a moderate to higher level of improvement and or be more satisfied with treatment. CPRs use science to predict outcomes and hopefully do better than educated guessing, but given the microclimates of your patients, it can be generally true, but not always true for the patient in front of you, and requires that you have to be the direct observer part of the decision, even when clinical prediction rules are used. Also remember that most clinical prediction rules have never made it past the first phase of testing, so that it's unknown whether the rule is applicable to different groups of patients or is feasible to use in the real-world environment. That being said, as a scientific practitioner, you can certainly test out these rules with your own patients to determine their value in your practice.